Yes, a very good morning to all. I hope my screen is visible. Okay, so today what we are going to do is to take up a few conceptual MCQs in dermatology. To introduce myself, I am Dr. Resham Vasani, your educator in the subject of dermatology on Unacademy platform. To tell you about Unacademy, these are the FMGE December 2021 toppers. They are all Unacademy students and they have done very well. To let you know about the free test calendar, which is available to all, it will be held on now 28th of Jan, and then it's also held on every Friday at 9 p.m., which is the Study With Me YouTube test series. Then alternate Sundays, it will be held at 9 a.m. for NEET PG 2022. And then alternate Sundays from 16 Jan onwards, it will be for FMGE grant tests. Okay, so there are free tests and there are tests which are for the subscribed people. Okay, so you can take a snapshot of this so that you can get access to all of this. Okay, and to tell you that when you want to get access to these kind of free tests, what you need to do is to enter the code mentor, MENTOR is the code which you will use to enter into this free test. A very good morning, Achkan Khan. So tell you about the plus subscription. See, why you should take up the plus subscription of Unacademy is because you get the best. You get access to both the live classes as well as you get access to the recorded classes. And you learn from India's top educators for medical examinations. You compete in live tests and quizzes. You study on a device of your choice, as well as you have an access to a question bank with more than 25,000 questions. Okay, you should also know about the iconic subscription of Unacademy. Iconic subscription of Unacademy gives you access to both the Unacademy as well as Prep Ladder. Okay, so through all the advantages of Unacademy, through Prep Ladder you have additional clinical and integrated essentials, video lectures from the Dream Team, question bank, rapid revision, snapshots and treasures in 2021 Dream Notes. To tell you about the special classes, you should definitely download the Unacademy Learning app and you do get access to these special classes which are interactive. You have polls which you can enter. You can raise a hand and you can talk to the educator live. That is something really, really interesting. You can talk to the educator live. You can resolve your doubts in real time. You never miss a class because you are always notified about the upcoming classes, the courses, and whatever recommendations they are curated just for you. Lecture notes in the PDF format are available at the end of each session, and you can attend the live classes, participate in the live chat, and get your doubts cleared all during the class. Okay, so I do expect an interactive session today as well. So do ask questions regarding the topics that we are discussing today or otherwise in dermatology. I'll be happy to answer. Also to tell you about the Unacademy Learning Bank or the question bank. Now this question bank, it's a highly effective question bank which has more than 25,000 questions. All these questions are based on the latest exam patterns and it includes detailed explanations. Okay, so after you're done with your studies, definitely you should go through all the questions so that you are thorough as well as you revise the topic completely before your examinations. So to get subscription to this particular question bank, you need to use the code mentor. MENTOR is the code that you need to use to enter into this question bank. As I've already told you, now you have a raise a hand feature where you can speak to the educators in the live class and therefore you can solve your doubts. It will be a 1:1 discussion, which has never happened with any virtual platform. To tell you about the upcoming batches, you have the Focus FMGE Comprehensive Batch. Okay, it's going to start off from 27th of Jan 2022. The duration of this batch is 5 months. So basically this batch will cover all the 19 subjects. There will be grant tests and subject tests which will be available. Recorded sessions will be available as well as PDF notes. And you have a practice question bank with more than 24,000 questions available with this particular batch. You also have a target NEET PG 2022 MCQ discussion batch, which will also start from 27th of Jan. It will go on for the next 2 months. Okay, all the advantages are also here in this batch. Then for the NEET PG subscription, so what you need to do is you can either opt for the plus subscription, which will get you access to Unacademy, or you can opt for the iconic subscription. Now if you opt for the plus subscription, say for example you opt for 12 months, the cost will be 24,750. The same subscription for 12 months in the iconic subscription, you will get it for 47,250. Please use the code MENTOR, MENTOR is the code which you need to enter to get access to this subscription and get an additional 10% off. Okay, so with that we begin our class. Okay, let's go to this first question. Sparing of the nose and the medial cheek, that is the perinasal area and the perioral area, even in extensive cases of atopic dermatitis, is called as. So you can see in this picture, this patient is having extensive atopic dermatitis, but you can see that the nose is definitely spared as well as the perinasal area is spared. Okay, so sparing of the nose and the medial cheek, that is the perinasal and the perioral areas in extensive cases of atopic dermatitis, what is it known as? Please write it in the chat box. What do you think is the answer? So Naveen says it's C. Anyone else? I see 20 people live. Come on people, you will have to answer. We have to make this session more interactive. Achkan, SVR, anyone? Okay, so the correct answer, as Santosh and Naveen have correctly, as well as Achkan has answered, is the headlight sign. Okay, headlight sign is the presence of the sparing of nose and the perinasal area even in extensive cases of atopic dermatitis. So basically what you need to know are the different signs. Okay, like for example the first, there is nothing as a light bulb sign. Okay, so that is completely out. Antenna sign is basically seen in patients with keratosis pilaris. Okay, what is keratosis pilaris? Keratosis pilaris is a minor manifestation of atopic dermatitis, or you can say it is one of the minor criteria for the diagnosis of atopic dermatitis. It presents as multiple follicular keratotic papular lesions which are seen usually on the extensor aspects of the upper and the lower extremities, as well as sometimes on the back and the face. It gives rise to that kind of a strawberry skin kind of an appearance. And if you see very minutely, you will see a kind of a follicular kind of an excrescence which is jutting out. Okay, so that is called as an antenna. That looks like an antenna, so that is called as an antenna sign, which is seen in keratosis pilaris, which is a minor manifestation or minor criterion for the diagnosis of atopic dermatitis. Then there is Herthoge's sign. What is Herthoge's sign? Herthoge's sign is also called as Queen Anne's sign. Okay, so it's called as Queen Anne's sign. So basically what is done in a Herthoge's sign is that you see in patients with atopic dermatitis as well as multiple other conditions, you see loss of the lateral 1/3 of the eyelashes. eyebrows. Okay, and that is called as the Queen Anne's sign or the Hertogay sign. Again, this can be seen in atopic dermatitis. You also see madarosis or loss of lateral one-third of the eyebrows in patients with hypothyroidism. Okay, so you see it in hypothyroidism. You can also see it in patients having infiltrative disorders like sarcoidosis, mucinosis, cutaneous T-cell lymphomas, as well as in conditions where there can be extreme pruritus like airborne contact dermatitis. Okay, and you can also see it sometimes in patients with alopecia areata and trichotillomania. Okay, so these are the multiple causes of uh, loss of lateral one-third of the eyelashes which can happen in atopic dermatitis as well, and that is called as the Hertogay's sign or the Queen Anne's sign. Now, what you need to know about atopic dermatitis is that atopic dermatitis is a condition in which is characterized by the presence of pruritus, okay, or itching. So, pruritus or itching is the hallmark of this disease. And in atopic dermatitis, itching often precedes the rash. So it is rather the itch that rashes than the rash that itches. Okay, so remember itching. So if they ask you what is the hallmark of atopic dermatitis, it is itching. So typically in patients with atopic dermatitis, you see an itch, scratch, itch cycle. So you have that sensation to itch. When you scratch, the sensation of itch perpetuates itself, and then you go into a cycle, and then this patient will only stop the scratching when there is bleeding, or when there is pain, or when there is burning sensation which is incited. Okay, so definitely itch is the disease in patients with atopic dermatitis. In addition, you also see certain vascular changes. Vascular changes like the periorbital, perioral and the perinasal pallor, which we just described as the headlight sign. And there is also white dermographism. Now remember, this is again a very important MCQ in patients with atopic dermatitis. White dermographism is seen in atopic dermatitis. Then there are certain triggers for aggravation of the itch in atopic dermatitis. Like you will see an aggravation in the presence of seasonal changes like winter. Winter is definitely an aggravating factor for atopic dermatitis because obviously the humidity levels in the environment are much lower. Okay, so that makes the skin even dry as compared to what it already was, and hence aggravates the atopic dermatitis. Woolen clothes, the fibers of the woolen clothing, they do irritate the skin. So basically the problem that happens in patients with atopic dermatitis is that there is impairment of the normal barrier. Okay, so when the barrier is impaired, what does the barrier do? The barrier keeps the things which are supposed to be there inside the skin inside, and things which are outside should not affect the skin. That is normal barrier function. So in patients with atopic dermatitis, this barrier of the skin is impaired, as a result of which the water which was supposed to be there inside the skin goes out into the environment, and the things which are very innocuous, but they start affecting the atopic skin. So woolen clothes, especially the woolen fibers, they do aggravate atopic dermatitis. Dust mites aggravate atopic dermatitis. Stress can be either forms. Even if the patient is, especially children, if they are very excited, okay, if they are very angry, if they have extremes of emotions, okay, they are going to scratch themselves badly. Okay, then there are food allergens which aggravate atopic dermatitis. So basically what happens in atopic dermatitis is there is transepidermal water loss. Transepidermal water loss happens because of the impaired barrier, right? And that eventuates into various inflammatory processes that happen in atopic dermatitis. Now, there are three stages that you see in atopic dermatitis. You have the infantile stage, which starts from 2 months of age and goes up to 2 years of age. Here, the involvement is mainly on the extensors. Okay, so remember in the infantile phase of atopic dermatitis, you have mainly extensor and facial involvement. Then comes the childhood phase, which is between 2 to 10 years. In this presentation, it is more on the flexures. So you see the lesions more on the flexures. In adult and adolescent atopic dermatitis, you see more of the involvement of the flexures, hands and feet. Okay, so there are two phases. There are like if you see eczema per se, or even or for that matter atopic dermatitis, you see that there can be three stages. One is the acute stage of eczema. In acute stage, you see more of vesicles and you see oozing. Then comes the subacute stage where you see vesicles, you see oozing, but you also see a lot of crusting. And then comes the chronic stage of eczema, which is characterized by lichenification. So what is lichenification? Lichenification is basically a descriptive terminology which involves three changes on the skin. One, there is hyperpigmentation, means the skin there tends to become darker. Okay, so there is hyperpigmentation. Second, there is thickening of the skin. So there is induration or there is thickening of the skin, and there is accentuation of the skin markings. Okay, so basically lichenification is a descriptive terminology which is comprising of hyperpigmentation, thickening of the skin and accentuation of the skin markings. So remember lichenification, again a very important MCQ here. Lichenification is something that you see in the chronic stage of atopic dermatitis. While acute stage you will see oozing, and basically on histopathology of the acute stage of eczema you are going to see spongiosis. What is spongiosis? Can someone tell me what is spongiosis? This is again a very important MCQ. In the acute phase of eczema, you see spongiosis on histopathology. Can someone tell me what is spongiosis? Anyone? Yes. So, Manasa, you're right. Basically, spongiosis means there is accumulation of fluid in between the cells. Okay, so it is intercellular edema, right? So, there is accumulation of fluid in between the cells, right? So, basically, what happens is that in spongiosis, when the accumulation of the fluid exceeds a certain extent, it forms a vesicle. So, there will be a accumulation of fluid in the epidermis. Okay, and that is called as spongiosis. So it will form a spongiotic vesicle. Okay, so that is what is spongiosis. So remember, whenever you are treating eczema, if you are dealing with the acute stage of eczema, when the lesions are wet, when the lesions are oozing, in that case, wet goes on wet. Remember that. Okay, so in the acute stage of eczema, your treatment will be to apply a wet compress. What is a wet compress? You take a muslin cloth, you soak it in warm water, remove the excess water, and just place it over the area where you have the oozing eczema. Okay, so that is going to dry out the eczema. It is going to stop the oozing. Okay, so remember, in the acute stage of eczema, your treatment will be with the help of a wet compress. So when it is wet, you apply a wet compress. Then in the chronic stage of eczema, see, basically what has happened in the chronic stage of eczema is that the skin has become thickened. Okay, so when you are applying something on the thickened skin, you need something that is occlusive, right? So you would need something that is having an ointment base, right? So that is why in chronic stage of eczema you will not prefer to use a cream or a gel or a lotion. You will prefer to use an ointment, okay, because ointment will have a oily base. Okay, and hence it will help the occlusive effect as well as it will improve the penetration of the active component, that is the steroid, within the skin, right? So that is something that you need to remember. So remember, in acute stage you will use wet compresses. If you have to use topical preparations, you will prefer to use water-based creams. While in the chronic phase of eczema, when the skin is lichenified, you would like to use ointments, and preferably you can use ointments which contain salicylic acid. Salicylic acid is something that is a keratolytic. So it will dissociate the keratinocytes and allow the steroid to penetrate deeper into the skin, right? So chronic stage of eczema, you would prefer to use ointments. So this is an image, a very, very classical image of the infantile phase of atopic dermatitis. Why infantile phase? Because you can see that the lesions are more on the face. You can see this annular lesion on the face here. This is an eczematous patch on the cheek of a child, and you see more of extensor involvement, right? So this is the extensor involvement of atopic dermatitis. So this is the infantile phase where you have more of extensors and facial involvement. This is a very, very important image because this has come as an MCQ as well. So they may give you an image of an infant with an eczematous patch over the face. They will give you a history that there is there is history of recurrent cough colds in the family, or asthma or allergies in the family. Okay, so what is your diagnosis? So this is nothing but atopic dermatitis in its infantile phase. Then comes the childhood phase of atopic dermatitis. In the childhood phase, as you can see, there is more of a flexural involvement. So you see involvement of typically the cubital foci. You will also see involvement of the popliteal foci. You will see involvement of the neck. Okay, so that is the childhood phase where it is more of a flexural distribution. And then comes the adult or the adolescent phase of atopic dermatitis, where you again see more of involvement of the flexures. So in the late stages, because of chronic and repeated itching and scratching, what you may end up with in the adult phase of atopic dermatitis is lichenification. So there can be lichenification of the flexures, that is involvement of the cubital and the popliteal foci. Now, a very, very, very important fact is that when you have to diagnose atopic dermatitis, you cannot use any blood test. Okay, so there is no blood test to use to diagnose atopic dermatitis. Okay, please remember, serum IgE is not diagnostic of atopic dermatitis. So you cannot diagnose atopic dermatitis solely on the basis of a raised serum IgE. Okay, so there is no patch test to diagnose atopic dermatitis. Remember that the patch test is used to diagnose contact dermatitis. Okay, so please remember, a patch test is used to diagnose contact dermatitis. You do not use it to diagnose atopic dermatitis. Okay, so this has to be very, very clear. The only way you can diagnose atopic dermatitis is by using criteria. Okay, so these criteria are basically major criteria and minor criteria. So when you see a constellation of symptoms and signs together which fit into the criteria, you diagnose it as a case of atopic dermatitis. So there are certain major criteria. The major criteria include pruritus. As I already mentioned to you, itching is something that has to be there for the diagnosis of atopic dermatitis. Okay, so pruritus is the most important major criterion. Then there has to be a typical distribution. So if you have an infantile phase, you will see it more on the extensors and the face. If it is the childhood or the adolescent phase, you will see it more on the flexures. It has to be a chronic and relapsing dermatitis. Like, it should not be a one-time thing. It should come, go. Okay. And next, there has to be a personal or a family history of atopic disease which has to be present. Okay. So these are the major criteria for diagnosis of atopic dermatitis. Remember the name of the criteria. Okay. Hanifin and Raika's criteria are used for the diagnosis of atopic dermatitis. There are 3 minor criteria which should be present. The minor criteria include the Denny-Morgan fold. What is Denny-Morgan fold? See, what happens is when children have atopic dermatitis, they also tend to have a lot of dryness which is there around the eyelid, okay, and the eye in the periorbital area. Okay, also they tend to have repeated episodes of eyelid eczema as well, and that causes a lot of itching on the eye as well as in the periorbital area, and they keep on rubbing their eyes very often. as a result of which you see a linear transverse crease under the lower eyelid. Okay, so that is called as the Denny-Morgan fold. Okay, so Denny-Morgan fold is the linear transverse crease under the lower eyelid. Then next is you see ichthyosis. What is the difference between ichthyosis and xerosis? See, if you see the criteria, you have ichthyosis as a criteria, you also have xerosis as a criteria. What is the difference between ichthyosis and xerosis? Xerosis is just dryness of the skin. Okay, you can see actually the skin is quite dry. That is dryness of the skin. Okay, what is ichthyosis? Ichthyosis where there is not just dryness, but you also have additionally fish-like scales. Okay, especially on the legs, on the extensor aspects, you end up having fish-like scales. Okay, so that is ichthyosis. In addition, these children also have hyperlinearity of the palms and soles. Okay, so that is another very important criterion. They have hyperlinearity. Hyperlinearity means you see more creases on the palms and the soles. Next is keratosis pilaris. Keratosis pilaris, I already mentioned what is it. Remember that the antenna sign. Okay, antenna sign is seen with keratosis pilaris. These individuals, they also have an elevated serum IgE, but please remember it is only a minor criterion. It is not a must for a diagnosis of atopic dermatitis. Okay. Also, as I mentioned that these children, they have an impaired barrier. So things which are outside can easily enter into the skin, right? So they are more prone to infections because bacteria are outside, viruses are outside, they can easily invade the skin. So they are more prone to cutaneous infections, especially Staphylococcus aureus and herpes simplex virus infection. Can someone tell me what is the condition in which you see extensive disseminated herpes simplex infection in a patient having extensive atopic dermatitis? Can someone tell me what is the name of the condition? What is the name of the condition in which you have extensive herpes simplex infection which can be invasive occurring in the setting of extensive atopic dermatitis? What is the condition called? Anyone? SVR, Manasa, Nirmala, Rajendra, Achkan, Ashwini. Anyone? Extensive disseminated herpes simplex occurring in the setting of atopic dermatitis is called as, it is called as Eczema herpeticum. Okay, it is also called as Kaposi's varicelliform eruption. Okay, this is very important MCQ. So please remember eczema herpeticum or Kaposi's varicelliform eruption is the dissemination of herpes simplex occurring in patients with extensive atopic dermatitis. Okay, and that happens not only in the setting of atopic dermatitis but in any skin condition which causes an impairment of the skin barrier, allowing the herpes simplex virus to invade the skin, disseminate, and then hematogenously disseminate is called as eczema herpeticum. So you not only see it in the setting of atopic dermatitis, but you can also see eczema herpeticum in the setting of seborrheic dermatitis at times. You can also see it in the setting of Darier's disease. Okay, you can also see it in the setting of pemphigus, especially pemphigus foliaceus. Okay, so these and sometimes in Haley disease as well. So basically, in any condition in which there is an impairment of the barrier, you will see that the herpes simplex, which is very common in the environment, it can easily invade. Okay, and then it can cause a dissemination. Okay, so this particular entity, it's kind of a dermatological emergency there can be involvement of the organs as well. There can be involvement of herpes associated hepatitis. There can be involvement of the CNS as well. So in such a case, you should be admitting the patient. You give the patient intravenous acyclovir, and of course take care of the existing problem which caused this particular dissemination. Okay. Then hand and foot eczema. Hand and foot eczema is more commonly seen in the adult as well as some pediatric forms of atopic dermatitis. Nipple eczema is seen. Dry lips and cheilitis is seen. What are the eye changes? Now, eye changes occur in patients with atopic dermatitis because of recurrent rubbing. Okay, so that can give rise to keratoconus. Anterior subcapsular cataract can also be caused because of it. White dermographism, again a very important MCQ. We have discussed this earlier. White dermographism is because of an abnormal vascular response that happens in patients with atopic dermatitis. Headlight sign we have already discussed. It is the thinning of the lateral eyebrows. What is Pityriasis alba? Pityriasis alba, again a very important MCQ. Pityriasis alba is one of the manifestations of atopic dermatitis. It's an endogenous eczema which manifests as a hypopigmented, minimally scaly patch on the face, usually seen in children. Okay, so Pityriasis alba, please remember, it's a kind of an endogenous eczema. Okay, and as I already mentioned, these children, they tend to have eyelid eczema recurrently. So this is a manifestation. As you can see, this patient is having multiple creases on the palms. Okay, so this is palmoplantar hyperlinearity, which you see in patients with atopic dermatitis. These are the typical fish-like scales that you see in ichthyosis, which can be associated with atopic dermatitis. Okay, so this is ichthyosis. Okay, this is white dermographism. So when I scratch the skin of a patient who is atopic, what do I expect? I generally I expect that the skin should go red in that area because of the triple response of Lewis. But that does not happen and the skin actually blanches. That's because of an abnormal vascular response that accompanies in patients with atopic dermatitis, and that is seen as a white dermographism. Okay, so please remember, white dermographism is seen in atopic dermatitis. This is hand and foot eczema, where you can see there is involvement with, you can see the fissuring. Okay, and this can be a quite a relapsing and a chronic condition which can be quite affecting the quality of life of the patient. This is Pityriasis alba, where you can see that it presents as a hypopigmented, minimally scaly patch on the face of usually a child. Okay, so you can see here. You can see here. So there can be multiple patches as well. So now the closest differential that you have to this condition or the differential diagnosis of a hypopigmented patch on the face of a child. So hypopigmented patch on the face of the child, when you get this kind of an MCQ, first of all, read the MCQ properly. They will give you certain clues. See, if they have mentioned that the patch is scaly, okay, then what are your differentials? The differential is Pityriasis Versicolor and Pityriasis Alba. In the MCQ, if they have not mentioned anything about scaling, then you assume it that it is non-scaly. Or if they have specifically mentioned, obviously it is non-scaly, it gives you a very big clue. Okay, so if it is non-scaly, then as Manasa correctly mentions, it is indeterminate Hansen's. It is likely to be, they are talking about indeterminate Hansen's disease. What is the other clue? One, Pityriasis versicolor will be usually perifollicular. It starts off in the perifollicular location, and then these perifollicular macules, they will coalesce together so as to form sheets of scaling. The typical involvement of Pityriasis versicolor is usually on the trunk, though it may also appear on the face. Another very simple way to differentiate between Pityriasis versicolor and Pityriasis alba is to look at the scale. The scales in Pityriasis versicolor, they are very fine and they are also called as brany scales, or they are also called as furfuraceous scales. So fine, brany, powdery, furfuraceous scales are seen with Pityriasis versicolor. Also, you have a sign that you can perform to diagnose pityriasis versicolor. Can someone tell me what is the sign associated with pityriasis versicolor? What is the sign that you see in pityriasis versicolor? Anyone? Manasa? The sign that you see in pityriasis versicolor is also called as the scratch sign, also called as the Besnier sign. No, SRV and hanging curtain sign is seen in pityriasis rosea. It is not seen in pityriasis versicolor. Okay. So, scratch sign, Besnier sign, also called as the Cobb de Anglais sign, also called as the nail sign. Okay, so there are four names to this sign: scratch sign, Besnier sign, Cobb de Anglais sign, and nail sign. They all are seen in patients with pityriasis versicolor. So when you scratch an area, it will show the presence of fine scaling. The scaling which was not apparent will now become more apparent when you scratch the lesion of pityriasis versicolor. Okay, so remember, scratch sign, Besnier sign, Cobb de Anglais sign or nail sign is seen in pityriasis versicolor. Okay, and another simple way to differentiate between Pityriasis alba and Pityriasis versicolor is to use something that is called as a Wood's lamp. What is Wood's lamp? Wood's lamp. So basically this Wood's lamp is basically containing a Wood's filter. Okay, and this Wood's filter will allow only 365 nanometers wavelength to pass through. As a result of which, what will happen is that particular area will fluoresce. In patients with pityriasis versicolor, you get a typical pale green or pale yellow. Okay, pale green or a pale yellow fluorescence is seen in pityriasis versicolor. Pityriasis alba is not going to fluoresce. Okay, so that is the difference. That is how you differentiate on a Wood's lamp examination between pityriasis alba and pityriasis versicolor. Okay, now that was about the differential diagnosis of scaly hypopigmented patches. If you see the differential diagnosis for non-scaly hypopigmented patch on the face of a child, your differential is indeterminate Hansen's disease. So what is indeterminate Hansen's disease? In indeterminate Hansen's disease, the disease has not yet decided which way to go. The body decides whether should I completely resolute on my own or should I go and downgrade into a very defined pattern of Hansen's, right? So that is indeterminate Hansen's disease. Please remember, indeterminate Hansen's disease, the lesion will be hypopigmented but non-scaly. The lesion will have normal sensation, normal sweating, and there will be no nerve to the patch palpable. There will be no thickened nerves palpable. Okay. On examination, if you do it very minutely, you will see the presence of atrophy. Okay, so atrophy is something that you see very commonly in indeterminate Hansen's disease. Okay, so the only way how you completely diagnose a case of indeterminate Hansen's disease is to do a biopsy. A biopsy may not show you the typical acid-fast bacilli, but it will definitely show you the presence of peri-appendageal and perineural lymphocytic infiltrate. So you have to do a clinico-pathological correlation and come to the conclusion of indeterminate Hansen's disease. This is keratosis pilaris, which I told you shows the antenna sign. As you can see, there are multiple grouped papules which are usually located on the extensor aspects of the extremities. Okay, now let's go to the next question. Look at this picture. Identify the hair. Which of these conditions shows this hair? Is it tinea capitis, androgenetic alopecia, alopecia areata, or lichen planopilaris? Anyone can tell me the answer? So Aishwarya says it's C. Anyone would want to add to it? Manasa says it's D. Okay, so let's see what is this image. So what do you see here? This is the structure of the hair. Okay, now here you are saying that the distal shaft of the hair is normal caliber, right? Then here you see that the proximal shaft has thinned out. That is the abnormal thing here, that the proximal shaft has thinned out. And you see a club shaped hair root. Okay, so this is nothing but an exclamation mark hair. Okay, so exclamation mark hair. Yes, Santosh and Aishwarya. The correct answer here is Alopecia areata. Okay, so in Alopecia areata, what exactly happens is that it is an autoimmune condition, right? So there are these abnormal cells which are produced in our body. Now these abnormal cells, they have to recognize something as an antigen, right? So what do? They recognize the melanin which is present within the hair bulb as to be the antigen, and they start attacking the melanin which is present in the hair bulb. So that is why what happens is it leads to the presence of certain dystrophic changes in the hair shaft. And that is, it causes the proximal hair shaft to become thinned out, and that gives rise to a typical appearance of an exclamation mark hair, which is seen as a normal distal end of the hair. There is proximal thinning, and then you see a club shaped root. Okay, so that is exclamation mark hair. So for this reason, because these abnormal cells, they target only the melanized hair follicles, because the antigen for the autoimmune response is the melanin which is present in the hair bulb, right? So that is why the white hair are spared in alopecia areata. Okay, so the patient may give you a history that I have gone gray overnight. Okay, my hair have turned white overnight. Why will the patient give you that history? Because the patient is losing all the black hair and only the white hair are remaining, right? So that is why the patient will say that I have gone gray overnight. Okay. Now, in tinea capitis, you will not see this kind of a proximally thinned out hair shaft. In tinea capitis of the non-inflammatory variant of the black dot variety, you will see the presence of black dots. Now, black dot variety of tinea capitis is caused by the endothrix organisms Trichophyton violacum and Trichophyton tonsurans. Okay, so in Trichophyton violations and Trichophyton tonsurans, they are endothrix organisms, means the spores and the fungal elements, they are present within the hair shaft. So when these fungal elements are present within the hair shaft, they are going to weaken the hair shaft, and as a result of which the hair will be broken off at the surface of the scalp. Okay, so you will see it as black dots, and that is why it is called as black dot variant of non-inflammatory tinea capitis. Okay, in androgenetic alopecia, you do not have just the proximal thinning of the hair. You have generalized thinning of the hair. So basically, what you will have in androgenetic alopecia is what you will have miniaturization. What is miniaturization? The hair which was thick, dark and deeply rooted in the scalp converts into a hair which is thinner, which is weaker and which is more superficially located in the scalp. Okay, so this process is called as the process of miniaturization, and ultimately what you land up with is villous hair, right? So the thick terminal hair is converted into a villous hair through the process of miniaturization. And why does this miniaturization occur in androgenetic alopecia? It occurs because of the influence of the hormone dihydrotestosterone. So under the influence of the DHT, the hair which were terminal, thick, dark and deeply rooted convert into hair which are thinner, weaker and more superficially located, and those are nothing but the villous hair. Okay, so that is what you see in androgenetic alopecia. Lichen planopilaris, please remember, it's a cause of cicatricial alopecia. What is the meaning of cicatricial alopecia? Cicatricial alopecia means there is complete loss of the hair bulb, right? So there is no hair present. There is cicatrization. There is scarring, right? So Santosh, it is not DHEA, it is DHT. Okay. So lichen planopilaris, you have cicatricial alopecia where you have scarring. That means once the hair is gone from that area, it is not going to come back. Okay, so you do not see any hair in patients having lichen planopilaris. Whatever hair which will be there, which will eventually get involved, will show the presence of a perifollicular pigmented halo or a grayish colored halo which will be present around the hair follicle, and you will see the presence of perifollicular scales and casts. Okay. Now, this is a very important topic, an MCQ rich topic, and that is alopecia areata. So, what happens in alopecia areata? It is an autoimmune condition, and as I mentioned, that these autoimmune lymphocytes, they damage the black pigmented anagen hair bulbs. Okay, why do they target the anagen hair bulbs? Because the telogen hair, they do not have the melanin in the hair bulb, right? So that is why they target the black pigmented anagen hair bulbs. Okay, so this is very important. They are going to target the anagen hair. Okay, and consequently there is hair loss. Hair bulge area. Remember the hair bulge area. What is the hair bulge area? The hair bulge area is the place where the erectopili muscle inserts itself into the hair follicle. Now that area where the erectopili muscle inserts is a kind of a bulge, and in that bulge you see the presence of stem cells. So stem cells are present at the site of the hair bulge, and if you have any inflammatory condition which is involving the bulge area of the hair follicle, what will happen? It will give rise to complete loss of hair, and that will be irreversible. Okay, so when the hair bulge area is involved, you get cicatricial alopecia or you get scarring alopecia. In patients with alopecia areata, the hair bulge which is having the stem cells is not involved. Okay, and that is why it is reversible or non-scarring alopecia. So remember, alopecia areata, it's a reversible and non-scarring alopecia. So what will be the history? Often the patient will notice that there will be a smooth hairless patch in one or more round or oval patches, usually on the scalp, beard area, eyebrows and the eyelashes. So alopecia areata can technically involve anywhere on the body. It can be present anywhere on the body. You see it on the scalp, you see it on the eyebrows, eyelashes, mustache area, beard area, body hair may also be involved. Okay, so there is often a smooth hairless patch in one or more round or oval patches, usually on the scalp, beard area, eyebrows, and eyelashes. Patchy hair loss with sparing of the white or grey hair in the patch is something that is observed, and that happens because the antigen is the melanin in the hair bulb. Okay, so white and the grey hair are spared. Some broken hair and black dots may be noticed in the patches. Now, please remember that alopecia areata not only involves the hair, but they also involves the nail. In the nail, typically you see the presence of regular pitting. So, pitting is the most common manifestation of alopecia areata involving the nail. The pitting is regular. So, you see regular pits which are transverse and longitudinal, and you have tracheonychia. What is tracheonychia? Trache means rough and nychia means nails. So basically you have roughened nails which are involving all the finger and the toenails. That is called as 20 nail dystrophy. Okay, so tracheonychia, please remember the most common condition that can cause tracheonychia is alopecia areata. Other conditions which can cause tracheonychia include psoriasis, lichen planus, eczema. But the most common to cause it is alopecia areata. Okay. So how do you differentiate between the pitting that you see in alopecia areata versus that in psoriasis? Now this is again a very important question. In patients with alopecia areata, as you know that the pitting is regular. It is having a typical Scotch plaid pattern. Okay. It is having a Scotch plaid pattern, regular, transverse and longitudinal pits are seen. Right. While in patients with psoriasis of the nails, the pits are typically irregular. Okay, they are not arranged horizontally and longitudinally. They are irregular and they are deeper pits as compared to in patients with alopecia areata. Okay, so irregular deeper pits are seen in patients with psoriasis. Then you have severe variants of alopecia areata, like there can be alopecia totalis. Alopecia totalis means loss of all the hair on the scalp. Alopecia universalis means not only the involvement of the scalp but also in the form of loss of hair all over the body. Then there is something very important which is called as oophiasis. Oophiasis means there are patches of hair loss along the temporal or the occipital hairline. Remember that whenever a patient of alopecia areata has loss of the hair along the hairline, that is on the temporal or the occipital area, it is called as oophiasis and it is supposed to be a poor prognostic marker for alopecia areata. Okay, so presence of oophiasis is a poor prognostic factor for alopecia areata. As you know, we saw it in the question itself, exclamation mark hair are seen in alopecia areata. So what are these exclamation mark hairs? See, normally the hair is going to taper in the top. But in alopecia areata, the hair increases in size as it rises up. Then it tapers in the middle. And then there is a hair bulb at the bottom. So that is called like, looks like an exclamation mark hair. And that is seen at the margins of the patch and indicates expanding disease. So remember that exclamation mark here is indicative of activity of a patch of alopecia areata and it indicates expanding disease. So this is a smooth, bald, hairless patch of alopecia areata involving the eyebrow. So remember that it is a smooth, bald, hairless patch. You don't have any kind of like black dots that you would see in patients with tinea capitis. There is no scaling. There is no redness. Okay. Now this is sesophiasis. So basically here you have involvement of the anterior hairline. Remember that in alopecia areata you usually see patches which are oval or round in shape. Okay, so smooth, hairless, round, oval patch of baldness on the scalp fits into the diagnosis of alopecia areata, and this patient is also having the sesophiasis pattern. This is the oophiatic pattern where you have involvement of the posterior hairline as well. This is alopecia totalis where the entire scalp is involved. This is the trichoscopic image of the exclamation mark here. So see, this is your club shaped root. Okay, so this is the club shaped root. This is the problem area. Okay, so this is the thinned out area. This is your proximal thinning which happens in patients with alopecia areata, and this is your normal diameter, normal caliber of the hair shaft. Okay, so this is a trichoscopic image of an exclamation mark hair. Now, if you do a histopathology of a patient having alopecia areata, what you will see are lymphocytes which will be present around the hair bulb. So, they will be kind of swarming the entire hair bulb like a swarm of bees. So, that is what it looks like on a histopathology, H&E stain. There are multiple associations of alopecia areata. Atopy, Down syndrome, other autoimmune conditions like SLE, autoimmune thyroiditis, vitiligo, they all can be the associations of alopecia areata. Now, how do you treat alopecia areata? See, some patches of alopecia areata, they may regrow on their own without any treatment. Okay, but if you have to give treatment to a patient with alopecia areata, your first line of treatment when the area of involvement of the scalp is less than 50% will be intralesional injections of steroid. So, intralesional injections of steroids is the treatment of choice when less than 50% of the scalp is affected. Topical minoxidil, topical anthralin can also be used. Phototherapy can also be used as immunosuppressive therapy. Okay, so this is when you have limited variants of alopecia areata which are involving less than 50% of the body surface area of the scalp. Now, what about patients who have extensive alopecia areata like alopecia totalis, alopecia universalis? Okay, in such a case, see, the earlier you treat the patient, the better it is. If the patient already has an established alopecia totalis going on for years together, okay, or has alopecia universalis since a very long time, there is very little that one can do, because even if you do give immunosuppressive therapy, the hair may come back temporarily but they can go away. So if the patient has established alopecia areata totalis or universalis or extensive variants of alopecia areata which have been very long standing, then better left alone. You can give them, offer them camouflage systems, you can offer them wigs, right? But if the patient has come to you early, okay, if the patient has come to you maybe say within a year of onset of alopecia areata, then it makes sense that we try our best to retain the hair and to bring back the lost hair. Okay, so now you have to look at the age of the patient. Now, if the patient is a child, you would definitely not want to use oral steroids, because oral steroids can cause stunting and can cause a lot of complications, especially in the pediatric age group. Okay, so in that case, what you have is something that is called as contact sensitization. So contact sensitization is a more effective therapy, but it comes with irritation. So it is useful for more extensive diseases like alopecia totalis or universalis. So what you do in this condition is that you apply an antigen like SADB, which is squaric acid dibutyl ester, or DNCB, which is dinitrochlorobenzene, or DPC. DPC is the commonly used content in practice, diphencyprone. It is applied onto the skin. Now these things, they are very very strong antigens. Okay, they are very strong allergens. So basically these newly applied chemicals on the skin, they act as strong competing antigens for the immune system. So basically contact sensitization works on the principle of antigenic competition. So basically what happens is that because now there are stronger allergens than the hair bulb, the immune system targets the new antigen instead, ignoring the hair bulb, and hence the hair regrows. So that is the sense in contact sensitization, which can be used as a modality of therapy in extensive cases of alopecia areata, especially in the pediatric age group where you would want to avoid immunosuppressives. Now, there are poor prognostic factors for the alopecia areata. One, when you have a very young person coming to you with alopecia areata. Secondly, if there is an extensive involvement already in the form of alopecia totalis universalis, if there is associated atopy, if there is associated nail involvement, if there is associated euphatic pattern, sesophatic pattern, if there is associated Down syndrome, thyroid disorders, all this is going to have a poor prognosis to alopecia areata. Okay, so that's the time we have today. So we have completed two very good topics, which will be, and we have discussed a lot of MCQs, almost around 30 to 50 MCQs we have discussed in this session. Okay, so we have discussed atopic dermatitis, we have discussed alopecia areata. Any questions, anything that you would like to ask me before I take your leave? Any questions? Okay, so if there are no questions, then I think we can end the session. Thank you very much for attending, and see you soon. See you on Unacademy special classes as well as the plus classes. Okay, bye. All the best.